I'm an Assistant Professor of Pediatrics and Director of the Neonatal Education and Simulation-Based Training Program here at UW. And this project started for me about 2.5 years ago with an encounter with a Gates program officer who was interested in VR. I was also interested in VR, so that worked out pretty well. I've been working in virtual reality and similar types of technology for about 7 years now. I started when I was a fellow in Indiana. It was a side project at that point and quite frowned upon by my primary mentor, as you might imagine, because he didn't think it would go anywhere, but it has gone somewhere. So, and he acknowledges it now. So, all right. So let's talk a little bit about our focus for today. I'm going to start out just with what we know, which is that neonatal mortality is a problem. I'm then going to go into not a whole lot of detail about the Helping Babies Breathe program because I think we're all pretty familiar with it, and as well as the implementation challenges that come along with the training of the trainer cascade. And then I'll spend some time talking about our project. mHBS stands for electronic HBB. It's a play on the E of everything at this point. And then mHBS stands for Mobile Helping Babies Survive. It's a combined digital health and mobile VR solution, and I will describe it in some detail, along with some of the preliminary studies that we've done, our development process, and the ongoing field test that we're doing in Nigeria and Kenya. And then in front of you are some low-cost VR headsets, so we'll have some time to do a demo, so you'll all get to experience eHBB and mHBS as well. So, in sub-Saharan Africa, intrapartum asphyxia accounts for the deaths of around 280,000 babies per year. And you can see on this map of the world neonatal mortality rates that this burden is disproportionately greater in sub-Saharan Africa than many other parts of the world. So if you can pick out Nigeria on the map, then you'll be able to see that the infant mortality or neonatal mortality rates there are in the red category. They range around 35 per 1,000, and that compares to the United States, which, depending on what estimates you believe or see, is somewhere in the range of 5 to 6 per 1,000. So magnitudes greater in parts of the world where we work. Kenya has the 10th highest neonatal mortality rate, and that's the other site that we're working at, but the main focus has been Nigeria because of its very significantly higher neonatal mortality rate. It's not like we, the collective we, have not been trying to fix this. We have. So there's a series of maternal and newborn education programs called the Helping Babies Survive series. And it's been around for a while. The flagship program, Helping Babies Breathe, rolled out in 2010 and was quite well received. As we are aware, around 500,000 birth attendants have been trained in 80 countries, and many countries have integrated this into their Ministry of Health plan, and they've been rolling it out consistently over a decade now. And the model that's been used is the training of the trainers model. I had the opportunity to first experience this in 2010. It wasn't in the context of Helping Babies Breathe. I actually vividly remember that I was in Kenya, or no, I was in Nigeria, being trained in essential newborn care when Helping Babies Breathe was being launched globally in the United States. I was like, oh, I wish I could be in both places. But you know, as part of a study, we were being trained, and then for 1 week, and then the next week we would be training community health workers. And this actually was my aha moment in, I would say, global health. I didn't know it at the time, but what I observed in those 2 weeks is kind of what led to what I'm doing now. Because I observed we were being trained by faculty from WHO, from the WHO. And the first week was very collegial. We were just, learning and doing all sorts of fun, engaging things to learn. It was very comfortable. Everybody was relaxed. We could tell that we were learning. And then the next week was when the community health workers came in, and my colleagues and myself, and we were training them. And immediately the environment adjusted. It was a lot more dictatorial, a lot more didactic, a lot more, you need to know this. It was just different. And I hadn't really been exposed to a lot of educational theory at that point. I was a second-year fellow in neonatology and very focused on clinical neonatology and maybe global health neonatology, but not sure exactly how much and where. But that was an aha moment for me. It was a different approach to education. It was like night and day. And it was not unfamiliar because I had grown up in Nigeria. I had come through the educational system there. I went to medical school in Nigeria. And so I recognized it as the very typical way that we teach there. But I think it was the prior week that had exposed me to a different way of teaching that somehow we were not able to translate the next week. So that, I stored that at the back of my mind. I didn't know what to do with it at the time, but thinking back, that's kind of what led me to where we are now. It was identifying the challenges of training of the trainer model. So we know that HBB training does improve the knowledge, skills, and ability of birth attendants to perform neonatal resuscitation immediately after the class. They feel very empowered. There's some sense of ability because they have just practiced these skills. However, there are clear barriers to HBB implementation that have been challenges over the years. And you can see in these images kind of the process of, first of all, this is a first room. Everything looks really nice and set up. There's some tablecloths. You can imagine that there's probably air conditioning. We have lots of trainers. Participant-trainer ratio looks pretty good. And then we're now translating that to the next level where it's not quite the same environment. I think I see some open windows and there are people learning. It still looks pretty good though. The fidelity looks decent. The trainer to participant ratio looks okay. And then you go to the next level where you have some people standing around, some people in the background, some people doing. This may represent what we see. And some of it is time constraints, some of it is facility constraints, some of it is the number of trainers that are available to train a large number of people. And those are kind of the obvious barriers. Then you go down a little bit deeper, as our partners at Laerdal Global Health have done, and they did a series of interviews and focus groups in Tanzania and other sites. And what they found was beyond the obvious, there's also a few other things. So lack of attention to maintaining the skills and confidence of the participants after initial training. Lack of emphasis on decision-making in scenarios that integrate cognitive and psychomotor skills. A lot of emphasis on how to perform the psychomotor skill of the bag and mask ventilation, but not necessarily how to activate or how quickly to begin or to persist if it doesn't initially seem to work. Those things are not as emphasized in training. There's also a lack of objective feedback and tracking learners' progress after the class. And this is all compounded by high staff turnover rates. Another barrier is the cost of training. So initial HBB training courses can cost over $4,000 per session, somewhere in the range of $3 to $4 million per country rollout based on the Tanzania estimate. And the maintenance training is something that a lot of people don't consider. So $2 million for a further 1 year, up to $5.5 million for another 5 years. That is generally not factored in. So everyone takes their Neonatalie and goes to somewhere and trains a bunch of people, and then what? And I think that's the question that we're all asking. What happens next? So, and then we have the evidence that indicates that initial HBB training alone is insufficient for transfer of skills, and providers need low-dose, high-frequency practice. Well, what is that? Okay, well, it means different things to different people. So this is one definition, but generally, frequent short practice bouts. So 5 to 10 minutes at a time, a dedicated HBB corner somewhere in the facility. It can be pretty basic, but gives them an opportunity to do some hands-on practice with the manikin. And then we get to where we are at this point. So virtual simulation is being used in a number of different arenas for adult, pediatric, and newborn intensive care resuscitation here in the US and other parts of the world. So what you see here, the images are of the program called eSIM, and eSIM is required as part of the preparation for providers who are taking a newborn resuscitation course now, as of 2 years ago. So this is an intervention that's been introduced, that's being used as part of preparation. It is screen-based, and it does require a pretty decent computer and internet connection. So it does not run on mobile phones, and so it is not particularly accessible in a low resource setting, but it is an intervention that we are currently studying, and the preliminary findings seem to indicate that it does help with the initial preparation and starting resuscitation and improving bag and mask ventilation, which is kind of the key component of helping babies breathe. So that said, since we have an intervention, but it doesn't really translate well to a setting without internet or high-end computers, could we use mobile VR? So as you all know, the smartphone penetrance and cellular network availability is reasonably high in many parts of the world. I remember going to villages in Nigeria that have internet, and I use Google Maps in a village, and it's really mind-blowing, something that would not have been possible 10 years ago. I was able to locate hotels in small towns in cities around the world using Google Maps. It was kind of mind-blowing, like I said. So, and beyond that, in education use cases, generally in school children, there is a high acceptance of VR, and the Google Expeditions is one of those examples. However, we don't know what healthcare providers will think, and we don't know if they would even consider using a tool like this. But why use it? Why would it work? Well, we know that it is a flexible option. It is a convenient option. You can use your own phone for it. You can use it anywhere you are. You don't have to go to a specific location. It provides an interactive experience, and so theoretically we could save time, we could save cost, particularly if it doesn't require continuous internet connection. It could potentially be accessible at a low cost for many people. Beyond that, it would provide a consistent educational approach. The thing with simulation is you can do this over and over and over again, and if you have a computer providing that opportunity, then it will always be consistent, and it will always provide consistent feedback, which is another big challenge that we face. So if we're going to a facility and maybe it's the matron and she's not doing it quite right, what do you say? You're not going to embarrass her in front of everybody, are you? You won't really be able to come back to that facility if you do that. So, I mean, it's just a tricky road to walk, and certainly if that's how we might feel, then how would someone else feel who works there? And that's how mistakes or poor performance get compounded. So, and then beyond that, we can extend simulation training beyond physical spaces. So we have simulation centers here in the US. They're very expensive to build and to run. That's not necessarily the model that we want to export, but could there be something else, some other option? So why would people learn better or at all in virtual reality? Well, there are some educational theories that apply, and they are based on these features. So first of all, the aspect of representational fidelity. So you can represent a realistic location, you can look around and feel like you're there. The objects in that environment behave as you expect them to, and you're represented by your avatar, that representation of yourself. And so you can hear objects, you can potentially touch objects, depending on the controllers that you have. And then if you have an environment in which you are interacting with either the computerized objects or individuals in the environment or an actual other person, then you can act and talk and control your environment and potentially create new content. So these two elements, the fidelity and the learner interaction, it is proposed, lead to a couple things. So you have an identity within this space, and you feel that you are there. And if someone else is there, you feel that they are there with you, which then leads to these learning benefits. So spatial knowledge representation speaks to the fact that most of us are able to remember things that we see a lot better than things that we hear. Experiential learning, we remember things if we do them. If we're paying attention and something is interesting to us, then we're engaged and we're likely to remember. If we're learning something in the context that we'll use it, we're also more likely to remember it. And if we're learning together, then there's an added benefit. So these are the things that VR could potentially do. But will it do it somewhere else? That's the question. So we started out with some landscape surveys, and one of which was conducted in Nigeria, and those are my Nigerian colleagues on the right and some Nigerian registrars and medical students in Abuja on the left. And these were the questions that we asked. So we know that simulation-based education using various modalities is increasing. However, we don't really know what providers think about this, and we just want to understand what the current status is. You know, do people have access to simulation in general? I'm not even talking about virtual simulation. And do they feel like it would be helpful? So we created a paper-based survey. It was a 35-item survey on simulation education, focusing on these aspects. Do you have access to a simulation center? Do you use simulation in any way as part of your work or as part of your learning? And what do you think about this? So this was given to a convenient sample of 350 healthcare workers and learners during simulation workshops and trainings in Nigeria, primarily at the 2018 Pediatric Association of Nigeria Conference and at the University of Lagos. And this was approved by the IRB. And this is what we found. So a total of 279 surveys were completed. They were primarily physicians and nurses, made up more than half of the respondents, and they were in both general and subspecialty practice, in pediatrics primarily. The respondents were mostly 21 to 30 years, and that's basically showing our student respondents, and female. And most had 5 to 10 years of experience in a tertiary care setting. And these were the results. So the manikin-based training was definitely more familiar, it was more common in practicing providers, particularly basic life support, which physicians, nurses, and medical students had all experienced to some degree. But again, those percentages were lower than what you would expect or want people that are in the medical profession to have been able to be trained in. Although the majority of physicians and medical students own smartphones. Again, validating what we know, 96% of people have a smartphone. Only 9% had experienced an online or virtual reality simulation. And of those, more students were aware of virtual training than practicing physicians or nurses, and that was significant. So we asked about perceived challenges. Well, most people just said that lack of awareness was the challenge. Others said lack of VR equipment or lack of standardized modules. But nearly all respondents felt that simulation-based education should be expanded for continuing education, teaching, and/or research. And if facilities were available, 97% would recommend the use of online simulation at their center. So I was not expecting that percentage, but that was encouraging, that people seemed open to online simulation or virtual simulation. We left it open to those big categories. And so our thoughts regarding this study are that many healthcare workers lack access to manikin-based training, and in spite of the challenges identified, healthcare providers and learners were open to the expansion of simulation, including virtual simulation for teaching, continuing education, and research. And the pictures you see there are from the National Hospital Abuja and from the University of Lagos. Sessions that we had with learners, just to, first of all, see, is it feasible to do virtual reality in these settings, and what do people think? So we actually had different levels of VR. On the far lower hand corner is our group of people using just a basic Google Cardboard device like you have in front of you. The top right corner shows a registrar using an Oculus Go, which is a kind of mid-level device, costs about $200. And then the students that are looking at the screen, I'll advance this a little further, and you can see a registrar showing another registrar how to use the game after about 30 minutes. I mean, they just took it over and they were ready to go. This was a pediatric case on seizure management that they were doing. So that is an Oculus Rift, which is a higher end device and requires a laptop. All these devices worked fine, to my surprise, because I went into this assuming that, yeah, maybe we could do VR on a mobile phone, but I don't know that we can do like Oculus and all these other things there. But they traveled well, they packed well, they set up fine, and the learners used them. So that was my surprise, actually. So these are the simulation facilities that are currently available at the University of Lagos. Again, another surprise, that there are simulation facilities. They are underutilized because most faculty do not have training in simulation facilitation or debriefing, but they're there. And that's a group of our faculty and project folks. And you might recognize the tall guy. Alex McGee is our project manager, and we'll be talking a little bit more about that. Okay, so let's launch into the EHBB mHBS project itself. But before I do that, I just want to pause to see if anyone has any questions on anything we've talked about so far.
About one of those, the most advanced simulation, the laptop-based one, used with the joystick controller.
Yes, it uses controllers.
Do you see a difference in the age of the providers and how fluent they are with that? There's a lot of talk about how people growing up now play video games, so they're good at being like drone pilots. Or whatever. So I'm just curious if you see the same thing, that some of the older providers
struggle a little bit. Yeah, I do see that. But I think a lot of it's not necessarily age-based, whether people will use technology or not. As you probably have figured out, that there are some people that are young that are pretty tech-phobic, and some older people are fine. So I would say that I have seen many young people do really well with controllers, and I've seen older people as well do well with them. It's how you introduce it, and also dependent on how the game itself is designed, because the game design itself plays into how well people are able to take it up and use it. Some people are, some games are really not intuitive, and that's the design, not the individual. So we'll be talking a lot about that actually next, because we put a lot of effort into designing EHBB to be very intuitive and very easy to understand. And it did not start out that way, but I believe it's close now, based on what we found. So yes, you have a question.
My understanding was that this is a complement to the manikin-based training, and if that's true, is there like an ideal ratio, I guess, of manikin stimulation to get like hand skills that you would need? Or?
I don't know the answer to that question. So manikin versus virtual simulation,
or like what the ideal of using both would be, I guess?
We don't know. That's an open area of research right now. I know in neonatal intubation, the skills that we learn on the manikin translate to clinical practice. I know as of now, we're looking at the cognitive aspects of using a virtual simulation with eSIM and seeing whether those translate to simulation performance. We'll be doing the same thing with the EHBB program. But neither of these tools have controllers with them. And so it's hard to say at this point whether any physical skills will translate. The things that I think will translate are activation, so knowing when to start positive pressure ventilation within that golden, well, not knowing, but actually doing. Because I think we all know and we teach to it, but do people actually do it? Does that time frame really sink in, and are people able to go through all the steps quickly enough, and are they motivated to go through all the steps quickly enough? That's one of the things that we're hoping to see, with our study here. And then the other thing is, the rate at which the breaths are given. Sometimes people bag too fast, sometimes people bag too slow. Sometimes they pause and do things like stimulate, check the baby again, and when really what that baby needs is bagging mass ventilation continuously for a period of time until the lungs are inflated and the heart has a chance to respond to that oxygen. So looking at the rate at which they give the breaths, looking at whether they start appropriately, looking at whether they continue for long enough to see an effect before stopping. I think those are the things that we may be able to see. And then also looking at, do people go through the process of correcting ventilation, so the ventilation corrective steps that are necessary if you're not initially seeing the chest rise, is another thing it's cognitive for the most part. I mean, you might intuitively squeeze harder, but to go through that process of, okay, it's not working, now I need to readjust the mask to make sure I have a good seal. Now I need to reposition the head. Now I need to make sure the mouth is open. Now I might need to suction again. And, then I squeeze harder. But, before, making sure that the airway is open, it's possible that those mental steps can be reinforced with VR. So those are the things that we think may help. Yeah. Okay. So this is the project we started in September of 2017. Yes. It feels like a lifetime ago now. And this diagram kind of shows the complexity of it. And we have multiple teams working to create the different components that are now being tested. So the first group is the EHBB team, and that consists of the University of Washington faculty and staff, the Oxford team from the University of Oxford in the UK, and the LIFE project, which is run by Michael English, The IU team provided input from the standpoint of HBB. We had some master trainers. The Kenya master trainer or country trainer was on that team, Sherry Booker, and Lerdal peripherally provided some input, mostly around the things that we've talked about, which were their findings from their focus groups. So that process led to the creation of EHBB, so a mobile virtual reality training app to augment healthcare worker resuscitation training. And like you said, not to replace the manikin-based training, but to augment it. And so the features of this, which we set out to achieve, were to have multiple simulations. So we have 3 pathways that the learner could go down, which mimic the Helping Babies Breathe action plan. In a case, they need to extensively resuscitate a baby. In another case, they only need to do some resuscitation for the baby to respond. And then in a third case, the baby goes down the green pathway, which means that it's born healthy and they just need to provide routine care. Again, complements in-class training, but provides individualized learning opportunities and standardized feedback. So from the technical standpoint, it requires only one download. It does not require internet use or access for use. And the usage data will upload when it's reconnected to the internet, so trainers and other faculty can see where the issues are. And we have it linked to a DHIS2 database, which means that access and performance data can be stored in conjunction with simulation performance and clinical data, which we'll go into more detail later. So the process for usability testing is outlined. We did usability testing in 2 sites. The Oxford team is based in Nairobi and worked at KEMRI to do some early usability testing with their colleagues there. And more formal usability testing happened in Nigeria at the National Hospital of Abuja. So we had approval from the National Hospital IRB, as well as the UW IRB and pretty much every other IRB on the planet, it felt like. There was a demographic survey, and we did a few tests. So the first impressions test, or the 5-second test, just gives a snapshot of what people think about the application, just from the visuals. Then we did user action tracking. So what did people click on first when they were directed to do a task? And how long did it take for them to figure out that that's what they needed to click on? And how long did it take for them to accomplish the task as a whole? And then we had open-ended survey questions as well as focus groups. So here's our team doing a session with a nurse at Abuja. And we had a cohort of 24. These were their ages. Most were female. They were primarily nurses and midwives. We had a few doctors. And we also looked at overall years of practice, which also kind of translates to age and ability to do certain skills. Prior exposure to manikin-based simulations, of which most of them had been previously trained with Helping Babies Breathe, and very few of them had been exposed to any online simulations, and none had been exposed to virtual reality simulations in the past. So a few of our findings, and recall that these were first-time users, first exposure, and very early on in the process. But overall, people thought that it was pretty appealing. Nobody thought it was complex or confusing, which was, I guess, good. And then the process of trying to figure out how to get people to go through the steps. And these numbers are just a snapshot. And again, early on, we found a lot of challenges with how we'd initially conceived the game to run. We initially had a process where people would teleport or kind of navigate around the room. We found that that was not very well easy for people to understand or do, and so we dispensed with that. We actually just have the game move people to where they need to be. So that took care of the time taken to find the mother, go to the equipment tray, go to the ventilation area. So now the game just moves you to where you need to be so that you can perform the actions that you need to perform. And so on. So these are a snapshot of all the skills that go into the process of resuscitating a baby. There are, I think, 20 of them total. Again, you wouldn't think helping babies breathe, it's so simple, right? You just do bag and mask ventilation. But no, there are many other steps that go into it. And again, that's, I think, the power of this, because they have to go through all the steps each time. So that reinforces the fact that no, it's just not just grab the baby and start ventilating. It's you have to be prepared, and you have to have your equipment, and you have to test your equipment, and you have to have it set up, and there needs to be a ventilation area for the baby. And then you do have the baby, and then you assess, and then you do this and that and the other before you start bag and mask ventilation. So over time, we got better with our task completion on first click. And this, again, is a snapshot of throughout this process, there was a rapid cycle of taking what we had found, implementing it, making changes, and I'll show you more about those, until people were able to clearly follow the directions, make the directions simple enough for people to follow, and ensure that they're able to complete the task. So some of the areas or categories that we addressed in the process were the instructions. You know, they're too quick to disappear, or the directions were hard to find, so we made some solutions for that. Objects, hard to click on, fix that. Animations, this is, you know, broken, it's continuing even after I want it to stop, fix that. Feedback on the form needs to be fixed. Graphics need to be improved. Curriculum. Well, so one in particular that I want to highlight is the last comment there. So the bulb syringe should come before the bag and mask is applied. Well, we wanted to actually maintain a de-emphasis on suctioning because that's new for the second edition. So as it is now in the game, if you go for the suction first, you'll get the baby doesn't require suctioning. Just to kind of walk people back from what they have really internalized and what actually has been found to be somewhat negative now. Because too long and too deep suctioning can actually promote bradycardia or a low heart rate. So we're trying to walk people back from what they have been now ingrained to do. And hopefully this will help with that too. So yeah, I think that summarizes some of the changes. And this process took about 9 months, just like having a baby. So, all right. So if all the facilities were available, this is what they thought. Also similar to what we found in our larger survey, that they would definitely recommend online simulation, and that they would be willing to test the next version. We asked them how likely they were to use the activity for practicing HBB skills, and they responded positively to that, as well as how likely they were to recommend this activity to a colleague. So here are some of our usability testers and their focus group discussions. And in summary, we did a lot of testing. So, and these are our colleagues at the National Hospital Abuja. The picture's a little dark, but that's Dr. Marami on the right there with me. And our HBB development team. Chris Payton is under Mike English, but he was the one that we worked closely with. He's a physician in Oxford. And the developer, Jacob, is on the right, right across from me, and he was indefatigable. He was really good. So, okay, now we'll go a little faster. And we'll talk about the data collection aspect of this, and the informatics people will be happy now to hear a little bit more about how this all ties into informatics. So the mHBS program, we set us out to do this, and when I say we, I mean Sherry Booker at Indiana University, who is leading this aspect of the project, has identified this issue with digital data collection, or data collection in general, and proposed that we do more digital data collection. So we integrated that into the project so that we would be able to collect data digitally on all of our project participants and test this other app along with eHBP. So as we know, there's a lot of difficulty with data loss and errors when you have paper data collection, and digital data collection has been proposed to be convenient, simple, and intuitive, and potentially reduce reporting burden. So we have two applications that are being used. One is the training app, which delivers the educational interventions that we're using in our study. And we can actually set it up so that only individuals that are randomized to a specific group can view an educational intervention. And the tracker app, which is an online survey and data collection tool. And this will enable us to link the educational and the clinical data. It's built on the DHIS2 mobile platform, and as you may be aware, data is collected and stored in the DHIS2 database, which is used by national ministries of health in over 40 countries. So right now, and along the line, we also, Sherry developed this digitized provider guide, which is the same as the paper provider guide. The reason for this was to be able to determine whether people were actually in the control group opening their provider guide or not. And we have a video to compare with the VR, which we filmed in Abuja in August. So right now there's seamless integration for the end user between these apps, and educational interventions can be accessed by learners from within the trainer app, and data can be tracked using the tracker app, and reports are sent to the project database. And so now we are in the study, and we've had several, let's see, I think we're up to about 60 participants recruited now between the two countries, Nigeria and Kenya, and we're recruiting from 20 secondary and tertiary health facilities in Lagos, Nigeria, and Busia in Western Kenya. The facilities were selected based on delivery volumes, the number of nursing staff, the presence of a neonatal unit, or association with a nursing or midwifery training program, and healthcare workers who are registered to take an in-person course or work in the appropriate wards are being approached for recruitment. All healthcare workers who provide neonatal resuscitation are eligible, and we kept our exclusion criteria very brief and few, but if they had received formal neonatal resuscitation training in the year preceding the study, they were excluded, or if they were people that did not provide neonatal resuscitation as part of their duties or couldn't do the follow-up, then we excluded them. So the study diagram is shown. This is kind of the first part. So we talked about the identifying subjects, randomizing participants. They are randomized to 3 groups. So we have a VR group, a video group, and a control group who get the standard of practice. And everyone gets a baseline knowledge check, and then they are allowed to use whichever intervention they've been randomized to before the course. Before they actually are trained, we do another knowledge check. We do a bag and mask ventilation skills check and a standardized simulation, which is, if you're familiar with HBB, is OSCE-A. So then they have the course, and immediately after the course, we do these checks again. And the pre and post course checks are actually standard for HBB training. Generally, the pre-check only involves the HBB knowledge check and the bag and mask skills check, but we included the standardized simulation in the pre-check to compare with the post-check. So after that, they have free access to whatever intervention they're in for 6 months, and at 1 month, 3 months, and 6 months, we again check their simulation performance. And during this time, we do kind of random observations. If they're working and they happen to attend a delivery and our research assistant happens to be there, they will observe their performance during an actual delivery, whether it requires resuscitation or not. And the goal here is not to just kind of stand at the side and watch somebody flounder, but what we're checking off is did they require any prompting or any assistance in X or Y skill, okay? And then finally, we have a post-survey and focus groups and key informant interviews. So the things that I'm going to start handing out now so that you can have a chance to see these various apps are the trainer app, the tracker app, and the eHBB. So the study dashboard, this is just a snapshot, allows us to see data as it comes in. So if any of these apps they all run offline, but if any of them happen to sync to the web, then we'll see the data as it comes in. So I'm going to go ahead and start handing off. Yeah. Mm-hmm.
So how is that being recorded? Like that's just routine data that is now being done through the app, or it's part of the training? Or?
So the data that's being recorded is at different levels. We do collect data within the mHBB performance, and we collect data on their knowledge and their skills, kind of in an educational setting. And then the third level of data collection is clinical data collection, which is observations in the delivery room.
And that's being done by the research assistant?
By the research assistant, using the tools. So for example, I'll just get you started off here. So this is the mHBS tracker app. And what it does is it allows us to collect data on individuals. If you click on the hamburger drop-down sign, we can go to the training app, and that opens up for participants to enter their study number, and then they access their specific study intervention. And then, if they are in the VR group, this is what they will see. So the way the VR app works is you put it into a VR headset, or you use one of those little devices that look like glasses. I'll show you how that works. So in the VR headset, the two sides turn into a hole, so it feels like you're actually in the VR space. You use this button to tap on the screen. So basically pushing the button is the same thing as tapping on the screen, which is what you would do with the glasses. And when you see that white dot change to a green circle, that means you can interact with that object. So you get to try it first. All right. So first thing to do is push the start button by clicking on that space. Yes, that is the usual response. Very cool. All right, so I'll show you with this one next how it goes. Okay, so these just flip over like little glasses, and then I look into the glasses and tap on the screen. So it'll show loading, and I'll just let you try it this one. Okay, so here I'll show them the room. So then you end up in a room like this with a mom and a menu in front of you. So you can select new game by looking at the menu. And when yep, there you go, tap. have a few more here. And then meanwhile, I'll also show you what they're seeing. So. Yeah, good question. So we had a lengthy debate about this from the standpoint of the project research team. And initially when we had conceived this, we said, you know what, VR can be used on devices as low as the Samsung Galaxy S4 device. We did a survey of what kinds of devices were available. And what we determined was that yes, VR was feasible and could potentially be used on their devices. And then we worked with the Oxford team, who was working with a VR game engine that was a little on the higher end and did not work on those low-end devices. So what the compromise in order to make sure that the study could go forward and ensure that everyone had equal access and we didn't just have a facility device, which eventually could happen. Except we know what happens to facility devices, right? Either they're locked up or they walk away, was that we would provide a device for each study participant, regardless of what group they're in. Because first we were going to provide it for the VR group, and maybe the video group, but the video group might not really need it. But then the PI said, well, you know, we can't just give it to one group and not the other. So we found some relatively low-cost devices, under $100. I think one device costs $60 and the other costs $80, and so we got those. Yeah. So you do not need to have a Samsung Galaxy S9 or anything like that. We got those here, but what would you like to see? Would you like to see the mHBS or the HBB for the groups here? There are two options. Okay, mHBS for you. Okay.
Are you talking about the application possibly to telemedicine?
Yes. So the application to telemedicine is that you could do a lot of training this way because you're remote and you're using a screen, but then you're kind of immersed within a space. So 360 video is one way to either do training, or if you're live streaming 360 video, you can live stream it to a VR headset. However, it does require a fair amount of bandwidth. So that would be the limiting factor if you were trying to live stream. Okay. So